No, there
There it goes. Hey everyone, thanks for joining us. All right, so we've got a good amount of folks, so I think we can get started. Today is a special version of our usual didactic calls for MathNet because we have our very own director of MathNet, Dr. Macheri Keshavan, here to talk to us about biomarkers in early psychosis. So by brief way of introduction, um, in addition to being the director of MathNet here, Dr. Macheri Keshavan is the Stanley Cobb Professor and academic head of the Harvard Department of Psychiatry here at Beth Israel Deaconess Medical Center. Dr. Keshavan has conducted early psychosis intervention and research for nearly 3 decades. He founded one of the first early psychosis clinical programs in Pittsburgh in 1990. And has published over 600 papers and 4 books on psychotic and related disorders. So Dr. Keshavan organizes educational conferences focused in early intervention for psychosis. He's been developing cognitive enhancement therapy, or CET, for schizophrenia. And today we'll talk about his work with biomarkers in psychosis. So I know we've had a couple of these talks recently focused in this area of diagnosis, differential diagnosis, kind of the overlap of psychosis in all these areas. I think this is very innovative research that kind of turns that whole idea on its head. So thank you, Kesh, for speaking with us today, and I'll turn it over to you.
All right. Thank you, Kelsey. I think the words you said of turning over its head is kind of exactly where I am hoping to go in this presentation, which is a little bit unusual, as you said. Let me first try to share my slides here. Okay. Can you see that in slideshow mode now?
Yep, looks good.
Yeah. Okay, so the goal of my presentation today is to give you a flavor of where the field of psychiatry is going, especially when it comes to psychosis research. And some of what I'm going to be telling you may not yet be in practice at this time, but hopefully will be in the years and decades to come. So I'm going to be talking about biomarkers and what we call biotypes, which is an alternative approach to psychiatric diagnosis as they apply to the early course of psychosis, which is the focus of this particular group. I'm hoping that some of my colleagues that join me in this research from around the country would join at some point, but if not, we are recording it anyway so that it could be valuable for other groups that work on similar lines as well. So let me see if the slides move. Okay. So the first question that we all should think about is, what do we do as clinicians of whatever stripes we come from, psychiatry, psychology, social work, and so on? We do 3 things. One is we try to understand the problem. We call that diagnosis. We try to predict outcomes. I mean, this is not just even for healthcare. If I have a problem with my car and take it to a mechanic, the mechanic will first run a computer diagnostics and tells me what's the problem. And then I ask the mechanic, what do I owe you and what's the outlook? Do I have to leave the car with you, or can I take it back home? And the mechanic will give an informed answer, you know. Maybe you need to leave the car here for a little bit, and it's kind of a major repair, or that something that is looking pretty good, may just a minor tweak, and you can go home. And then, of course, the mechanic or the doctor will also have to use that information of diagnosis and the outcome prediction to decide what's the best outcome or what's the best plan for treatment. So these are the three things I'm going to be talking about today: diagnosis, prognosis, and treatment choice. Now, how does a clinician in the rest of medicine approach diagnosis? I'll give you an example of my own case. About 15 years ago, I was driving to work to Beth Israel Deaconess Medical Center, and I had a sudden chest pain. So instead of going to the landmark center where our building was at that time, I drove to the emergency room. They took me in right away, and the doctor scratched his head. So a middle-aged man at that time coming in with a chest pain must be the heart. So he ran a cardiac cath on me, and everything was fine. So by a process of exclusion, he came to the conclusion that it was not a heart problem, but it was a gallbladder problem, which must have caused the chest pain. So this is the way doctors in medicine, oncology, neurology make their diagnoses. Diagnosis by examination, laboratory investigations, and then like a detective going into the diagnosis. But what about the rest? What about psychiatry? I'll give you another example of a young woman I took care of over maybe 30, 40 years ago when I first began as a psychiatrist. She said, when I took a detailed history, she had attention problems in childhood. And then as she was growing up into high school, she had kind of social withdrawal, social anxiety. Then she started getting depressed. And then she started having mood lability, mood changes. And then more recently, she had started having suspicious thoughts and hearing voices. So I asked her, Mary, what diagnoses did the doctors give you? Doc, they called me ADHD in childhood. They called me anxiety disorder in high school. And then they called me bipolar disorder last year. But today you're saying that I have a psychotic disorder. So she asked the next question, which was quite embarrassing to me. Now, what label are you going to give me, doc? What does it mean for my treatment? How can I talk to others about my diagnosis? So, in other words, the sobering lesson here is in psychiatry, we still use labels to make our diagnosis. If someone says he's anxious, call it anxiety disorder. Someone has no attention, call it ADHD. Someone who has a mood disorder, call it bipolar disorder. We are just using psychiatric diagnoses as labels, as adjectives. So that's really not a very satisfactory state of affairs. So that question brings us to the question as to why do we even make a diagnosis? What is the purpose of diagnoses? Are our diagnoses valid? There are some useful things about the way we make diagnoses. We use the diagnostic label to communicate with other professionals, to tell the insurance company, what to pay us for and what to charge the patient for legal purposes. This is all good utilitarian aspects of the diagnosis. And are they reliable? Yes, they used to be very unreliable until DSM-3 came along. And DSM-3 developed what are called operational diagnostic criteria. You have to have four of these six, or you have to 7 of these 11, and then you are good to go with this diagnosis and so on. So that improved reliability. But are they valid? If you say somebody has depression, does it pick up an entity, a disorder that has a characteristic biological basis, or we call it schizophrenia or bipolar disorder? Does it pick up something that is distinct in reality, in nature? And does that diagnosis help us predict the right treatment? And does that help us to tell the patient what's likely What is the likely outcome 5 years from now? And also, does that diagnostic label help us identify better treatments? Answer is no, or we don't know. So that brings us to the question, are psychiatric diagnoses valid? They're reliable, but are they valid? So that brings us to the question of what is reliability and what is validity. In this cartoon, this archer is shooting the arrows. They all fall at the same point very reliably, but they miss the target. This is an example of good reliability but poor validity. What you want is to pick up the right entity and make that diagnosis reliably. That is where we should be, but we are not there yet. And how does one do that? So that is where brain biomarkers come in. Kind of, if the car is taken to a mechanic, he doesn't make a diagnosis right away. He looks under the hood. That is biomarkers. And there are a number of those. You can look at brain wave patterns, which is EEG. You can look at brain structure and function and chemistry, which is brain scans, and cognition, measuring cognition tests, batteries, and so on. But these, I'm going to show you a bit later, these biomarkers, simple, straightforward use have not helped us so far, and I'll tell you why. So first of all, what is a biomarker? A biomarker is a measurable indicator of a biological state or condition. In medicine, it could be a substance, molecule, gene, or a process that signals the presence, progression, a response to a disease or treatment. Essentially, it's a measurable characteristic that helps doctors assess health, diagnose diseases, monitor progression, and determine how the body is responding to treatment. This is the FDA definition. There are different types of biomarkers, those that are used to make a diagnosis, those that are used to predict outcomes, and those that are used to select treatment. So I'm going to touch a little bit on each of those as we go forward. How do you develop biomarkers and biological diagnoses, which is what we call biotypes in psychiatry? First of all, one needs to identify the appropriate test, biomarker. And secondly, choose the one that add value in addition to the existing clinical tools. Secondly, you have to confirm that the biomarker that you are considering reflects the underlying disease process. To give you a straightforward example, if somebody says a biomarker is the color of your eye, but does the color of the eye actually relate to the brain function which underlies a disease like schizophrenia or not? If it doesn't, it is a biomarker, yes, but it is not a biomarker of value or validity to the underlying illness. The second thing you have to establish is whether it is something that if you test today and you test again a few months later, you'll still be able to see the same thing. Are they stable? And thirdly, you need to know, fourthly, you need to know whether in a very different sample you can replicate the same results. And fifthly, how do you know that they're useful? Do they help us predict outcomes? Do they help us guide treatment choice? So any good biomarker must be scalable to the community, not just in the ivory tower like Harvard Medical School. They should be cost effective and they should be viable in clinical settings, like in a community clinic. So we have been interested in this question for quite a long time, for over 20 years. We are a group of researchers around the country. We form a group called Bipolar Schizophrenia Network for Intermediate Phenotypes, which I won't go into too many details of how we came up with this complicated name. But suffice it to say, we are focused on biomarkers. And our argument, going back 20 years, was that schizophrenia and bipolar disorder and schizoaffective disorder, this is a classification that Emil Kraepelin, the father of psychiatry, whose sketch is here, came up with about 120 years ago. And we still hold on to that in our DSM. And we wanted to ask the question whether biomarkers distinguish between these three conditions: schizophrenia, schizoaffective, and psychotic bipolar disorders. Our very naive and simplistic hypothesis was that if you use straightforward, well-known markers of brain structure and function, they will neatly follow this categorization of schizophrenia versus bipolar disorder versus schizoaffective disorder. So this is how we wrote a grant 15 years ago, and the NIH funded us for it. We studied thousands of patients with these biomarkers, and at the end of the 5 years, we looked at the data, and we came up with a zilch, zero result. There was no clear difference between schizophrenia and bipolar disorder and schizoaffective disorder in whatever biomarker you looked at. They were all abnormal compared to controls, but they did not distinguish between each other. A little bit quantitatively different, but schizophrenia had more brain structural loss, schizoaffective was somewhere in the middle, and bipolar was the least. Same thing with regard to the amplitude of their brain oscillations, or what we call evoked response potentials. The same thing is also true at the top of their cognition. Schizophrenia was the most abnormal in black, schizoaffective disorder in gray, in the intermediate, and bipolar disorder in white, the least cognitively impaired. So we scratch our heads. Where do we go from here? So this is what led us to think of the question a little bit different. And that is, just forget about DSM diagnosis. Let's give this information agnostic to DSM without letting the computer know that these are the clinical diagnoses we made, and use machine learning to classify these individuals, about 700 of them, into categories based on biology. That is what we call biotypes. And the machine learning algorithm faithfully came up with 3 biological subtypes. We call them biotypes: biotype 1, biotype 2, and biotype 3. And what you see at the top left here are the scatter plots based on biology. On the top left, what you see here, they neatly fall into 3 categories, which we call biotypes 1, 2, and 3. But the same biology, same biological measures did not at all separate across the 3 DSM categories. And then if you looked at the biotypes, and the 3 different biotypes are in red, green, and blue respectively, they approximately similarly distributed themselves across the 3 biological subtypes. In other words, the biology, DSM did not read biology. Okay, they were kind of different ways of slicing the pie. And then, we needed to know whether this is real. You can only know something is real in science if you can do the same thing in another group of patients and you come up with the same result. So we took another 800 people. We applied for a grant, and in the BSNP2, we exactly used the same biomarker methodology and see whether they follow similar lines. And each of these figures, the hard line is the first BSNP study, and the dashed lines is the second BSNP study. As you see here, the patterns of change in the different biomarkers between the green, blue, and red were pretty much the same in the first study and the second study, suggesting that biologically these brains can be classified in exactly the same way, even if it is an entirely different sample of patients. So they're replicable. Are they stable? Now, since this is a early psychosis group, I'm showing you the results of the early course versus the more chronic patients. What we found was that the biotype 1, 2, and 3 were similarly distributed in the early course patients with less than 10 years of illness duration versus the more chronic patients that is more than 10 years of illness duration at the bottom. So these biotypes are stable and do not differ in regard to the course of the illness. Now, are they valid? We did not use any clinical information to classify these categories, but we found that biotype 1 had the most deficit symptoms. This is what Kraepelin would have called a dementia precox kind of symptoms. They had the most significant cognitive impairment and they had the most significant deficit symptoms. Then we looked at other aspects of biology that we had not used in construction of these biotypes. And one of the ones that we were very interested in is the hippocampus, which is an important structure in the brain for cognition. It is present deep in the brain. It looks like a seahorse, which is why it is called hippocampus. And we found that the biotype 1, which is the most cognitively impaired, is the one that showed the most prominent hippocampal volume loss and the amygdala volume loss. Remember that people with some psychotic disorders, especially schizophrenia, they have more of a flat affect, a blunted emotional response, and also cognitive impairment. So the amygdala and the hippocampi are most abnormal in biotype 1, and biotype 2 and 3 did not seem to differ. But when you classify them based on DSM, they all showed some similar things. So really, this biotype classification is picking up something biologically different, biologically unique. One of our postdocs, Sinead Kelly, looked at this data using a different approach by measuring brain's free water. That is an index of brain inflammation. And she found that the biotype 2 had the higher levels of brain inflammation. I can give you several other examples of how these biotypes differ from each other in terms of brain structure, function, and so on, but I'm just giving you a few examples.
Cash, there's a question in the chat. If you can go back to the hippocampus scans.
Yeah.
Can you say more about what the colors are indicating?
The color red is the most gray matter loss.
Mm.
Green is the next most gray matter loss. And white or no color means no structural change.
Thank you. Yeah, very interesting.
Okay. Now, one of our faculty, Walid Yassin, who's a machine learning expert, he took a very different approach to biotypes. He reclassified these patients into subtypes based on causation, etiology. And he came up with 4 subtypes, actually. One was a subtype that was predominantly determined by associated with high levels of substance abuse. And that is cluster number 1. And cluster 2 is those with both substance use and high childhood exposure to trauma. And then the third group had neither of those. And the fourth group had only high trauma. And then he looked at polygene scores, the strength of genetic contribution that was highest in those in whom the psychosis had happened even in the absence of any kind of traumatic experience or a cannabis exposure. Whereas what we call exposure types, that is high levels of environmental risk exposure, especially those who use cannabis and have developed psychosis, tend to have the lowest genetic risk. And also interestingly, The group with the highest cannabis exposure were the ones we called biotype 3 in our biomarker classification. So the biology and etiology in some ways are going together. Interestingly, the biotype 2 were a little bit more in biotype 1 and 3, 1 and 2. And the cognitively most intact group was the group with high substance abuse. That's interesting. One could argue that you need a little bit of cognition in order to be able to get the drugs on the street and use them. But anyway, if you looked at people with cognitive impairment, without cognitive impairment, those without cognitive impairment had more substance abuse, and those with cognitive impairment had more genetic factors. So up to this point, in terms of biomarkers and diagnoses, the summary is that current DSM diagnoses may be reliable, may be useful, but they may lack validity and stability. Biomarker-derived diagnosis may be more stable and may more validly identify biological subtypes. A more refined approach to diagnosis may yield a better ability to predict outcomes, such as a biomarker-based approach may tell us how to predict outcomes and how to choose treatments better, which I'll come to in the second and third parts of my talk. There are other biomarkers that are promising in the literature, which I won't go into these details. If people have questions, I'll come back to this slide a little bit. So this is a very active area of research. Now, can biomarkers and biotypes predict outcome? So that's my second question. So I'll again go back to a patient. I mean, I always learn from my patients, and throughout my career, most of the important insights have come to me from talking to people with experience of illness. So one of my patients, who was a bright medical student, this was about 35 years ago. Let's call her Maria. So she came to me with what appeared like a first psychotic episode. She was 24 when the voices started. And, I made a diagnosis of schizophrenia. She was shocked with the diagnosis of schizophrenia because she had been reading about schizophrenia in her books and classes, and she thought it was like a sentence to her, like a death sentence. So in her next visit, she asked me, what is the outlook? How long should I take medications? So I told her, the way we understand this illness, schizophrenia, you probably will have this illness for the rest of your life, maybe for a long time. You need to continue taking these medications indefinitely. This was our state of knowledge, 4 decades ago. And in many ways, this is still the way many clinicians think. So she was really very disappointed. She came to see me maybe a few more times, and then she dropped out of treatment. And I didn't follow her up. I didn't know what happened to her. When she first saw me, she was a fourth-year medical student, and I assumed she dropped out of her college. And so I'll come back to that a bit later. So prediction is important. She had asked me a prediction question. How long should I take my medications? What is my outlook? Yogi Berra said it is tough to make predictions, especially about the future. That's exactly where we are in psychiatry. And studies have shown that any gut feeling is notoriously unreliable. Data-based predictions are a little better. So that's my preamble to the next section of what I'm going to talk about. And as I said, I was talking like Emil Kraepelin would have talked about dementia precox about 100 years ago. He said the patient may never achieve restitutio ad integrum. The patient may never achieve a pre-morbid level of functioning. But some others, like Bloiler, had a different viewpoint. The sooner they can be restored to an earlier life and the less they are allowed to withdraw into the world of their own ideas, the sooner will they get better. This is kind of an early um, introduction to the idea of early intervention in psychosis by Eugene Bloiler, 1908. But people forgot that, and then in the 1990s, they started thinking back on those lines. Outcome of schizophrenia is variable. There are those who have a chronic, persistent, declining illness, about a third of them. About a third have episodic versus inter-episode deficits. About a third have either a single episode with full remission or an episodic illness without inter-episode deficits. We don't know which of them will have one episode and no more episodes, maybe about 10% of them, but we have no idea at this time as to how to predict them. The majority have some level of illness, recurrence or chronicity or persistence. We did this study in a first episode antipsychotic naive cohort in Pittsburgh going back about 20 years ago. That data was looked at recently. And we found that when you followed them up, they had four trajectories. There were those who did well. There were those who did not do well at all. Though there were those who were doing poorly to begin with, but were catching up. And then there were those who actually got even worse. How do we know what predicts outcome? And I classify them into two kinds of predictors. There are those that you can't do much about, non-malleable or non-reversible predictors. And then there are those where you can do something about, which is what I call the ABCDs of our predictors. So adherence, brain measures, cannabis and other substance use, and delay in treatment. I'll take each one of them in turn. And then we'll talk about biomarkers. This is our own data from Pittsburgh. There was no effect of gender, even though the literature says that men tend to have a somewhat poorer outcome. And we also looked at race, and it looked like African Americans had a somewhat poorer outcome, which we published. Diagnosis also matters. Those who have a schizophrenia psychosis have a poorer outcome compared to non-schizophrenia psychosis outcomes. So these are, you could say that you can't change gender or ethnicity. You can't change the diagnosis, but there are changeable things. Number one, adherence to treatment. In this very early study that we did, a simple question we asked: did they come back for follow-up after the discharge from hospital, or did they not? That one question was able to predict outcome 6 months, 12 months, and 24 months, and 48 months later. Single question: did they show up or did they not show up after the first episode? So adherence is a very, very important predictor. Cognition is an important predictor. And now number of studies have shown this, including our own Pittsburgh studies. Those who have poorer cognition tend to do more poorly. And we also found that the more brain gray matter loss they have, the worse is the outcome. So this is a meta-analysis that we did based on a lot of imaging studies. We found that brain structural abnormality, frontotemporal gray matter loss, is a good predictor of poor outcome in schizophrenia. And then there are also, there is substance abuse. We know that cannabis abuse predicts relapse, and non-adherence mediates this effect. The more they continue cannabis after the first psychotic episode, the worse is their outcome. That has been shown by a number of studies. And also, cannabis may, if it is associated with brain structural abnormalities, it may be related to worse outcome. So this is the data from Weibel et al., who showed that continuous users had worse outcomes compared to on and off users versus the abstinent users, which was the red line, in which case they not only reduced their PANS negative symptoms, but stayed low. Treatment delay is another important predictor. This is data from our own first episode psychosis study going back about almost 2 decades, more than 2 decades. We found that the longer untreated illness they had, the worse was their outcome at 1 and 2 years follow-up. So, a summary from that point is that 4 things, namely delay in treatment, adherence to treatment, cannabis and other drugs, and cognitive dysfunction and brain structural abnormalities, they're all related to poor functional recovery and poor outcome. So what about biomarkers? How much do they add to this kind of a predictive value? That's a question for the field, and my a review of literature suggests that they do add value, especially cognitive assessments at the baseline, EEG measurements, and brain scans. So this is what led us to go back to our BSNP data, which I already showed you, the 3 biological subtypes, and we made the prediction that the biological subtype 1 and subtype 2, which are associated with more cognitive impairment and more brain abnormalities, are the ones that might show worse outcomes. And biotype 3, which is associated with a more intact cognition and intact brain structure, might be associated with a somewhat better outcome unless they continue to use cannabis. So that was our overall prediction. Biotype 1 and 2, along, if you combine that information along with other features like clinical information, cannabis use, trauma history, duration of untreated psychosis, treatment response, and adherence, all of that might help us predict outcome. So that's the summary up to this point. The outcome trajectories in psychosis are variable, but increasingly optimistic. Predictors can be non-reversible, but may also be reversible. Brain structure and function may mediate outcome, and these are changeable, plastic, and potentially reversible. Early identification of such biological signatures may thus assist early intervention.
We
And
have
these
another, oh, sorry, I was looking at another question in the chat, kind of pointing out that a lot of these features, so cognitive impairment, gray matter loss, brain inflammation, substance use, physiological functioning. So these are all also features seen in people with chronic experiences of extreme traumatic stress. And so how are you guys thinking about trauma and also kind of, social determinants of health? So things like people's built environments, racism, all of these bigger social structures and how they affect those.
Yeah, those are excellent questions. And in fact, some of our research has focused on that. Elizabeth Del Rey in our group recently published a paper showing that those who had a history of trauma in childhood had not only an earlier age of onset of psychosis, but also more gray matter abnormalities, more hippocampal volume loss, and more cognitive impairment. So trauma is very, very important. So any effort to predict outcomes, we need to take histories of trauma and discrimination and more recent psychosocial stress into consideration as well.
Yeah, it stands out. I mean, the earlier in onset too, likely the longer that duration of untreated illnesses too. So all of these are so interconnected.
Yeah, exactly. So the main point is that there are many factors that predict outcome, and a better way to predict outcome would be not a gut feeling, but a multivariate prediction. One can use calculators, for example, in the prodromal research. Now there are calculators available for predicting psychosis in those who are at clinical high risk for psychosis. And such calculators have not yet been developed to predict relapse and predict outcome in first episode schizophrenia. Psychosis, hopefully, some of the data that we are collecting might someday allow us to do that. So that brings me to the study that we are doing at this time, which is called BICEPS. This stands for Biomarkers Course of Early Psychosis um, in Specialty Services in Psychosis. So that's called the BICEPS study, where we collect all of this information, including clinical data, substance use data, pre-morbid adjustment, digital phenotyping, cognition, social and role functioning, and of course, biomarkers. We do EEG, eye tracking, brain imaging, and blood biomarkers for DNA and so on. The goal is to characterize outcome trajectories and also predict outcomes, and using these multiple sets of information to develop decision tools, algorithms for clinicians for outcome selection and treatment selection, outcome prediction and treatment selection. So the third main part of what I'm going to talk about is about whether we can predict treatment response in psychosis, not just in the early course psychosis, but across all phases of the illness. Can this kind of biomarker characterization or biotype characterization help prediction of treatment response? I'll give you one example, which is with clozapine, but similar questions may be asked about other treatments in psychiatry as well. As you all know, clozapine is a medication that is at this time reserved for people who fail at least 2 antipsychotic drugs. What we do know is that about a third of people with psychotic illnesses, including schizophrenia and schizoaffective and bipolar disorders, about a third do not respond to conventional antipsychotics, either first generation or second generation. And then these are the people in whom we consider clozapine. And if you use clozapine, even among them, about a third do not even respond to clozapine. You may have to use ECT, or you may combine the clozapine with another antipsychotic, and so on. So clozapine is a good drug, sometimes life-changing in people who don't respond to standard treatments. But it has its problems. It doesn't work for everybody, and also it's a complex drug. It has got multiple effects, causes weight gain, sedation, postural hypotension, constipation, and so on. It is free from extrapyramidal side effects like Parkinson's, akathisia, and so on. But, it's a complicated drug to use. I'll show that in the next slide. So it is highly effective. If you look at the effect sizes of the various antipsychotics, clozapine is at the top. The other drugs may have slight differences between each other. Olanzapine and risperidone being the more reliable ones, but not hugely different from other second generation or atypical antipsychotic drugs. But clozapine has significant side effects. The one that most people are worried about is agranulocytosis, that is a drop in white blood cells, which could increase the risk of life-threatening infections. Because of that, they need to be regularly monitored, initially weekly, to do a white blood cell count. Until a few months ago, FDA made it a mandatory requirement that would have a weekly blood draw during the first 6 months, followed by every 2 weeks for this next 6 months, and then once a month, and so on. A lot of patients and families were unhappy about that, and so They appealed this and it has now been dropped. But still, the clinical wisdom is that we need to continue monitoring individuals with regular monitoring. The other problem is, which is a more common problem, is weight gain, which also comes with metabolic syndrome, dyslipidemia. So that's a significant problem. And another significant problem is myocarditis, um, which could be an inflammation of the heart. Not common, but if it happens, it is pretty serious. So it has to be monitored and prevented. Constipation is a huge problem in many people, and so is drooling, and epileptic seizures can happen. So remember this as the ABCDEs of clozapine side effects. It's a good drug, but it, has a number of issues. So how can we make sure that we choose the right people to get clozapine and so that we use them more effectively? And there is an interesting clue in the literature, and that is, I told you clozapine can increase risk of seizures, and it does so in a dose-dependent way. The higher the clozapine dose, the higher the clozapine blood level, the higher the number of cases with abnormal EEG, the more likely is the seizure, but also perhaps more likely is the effect. But nobody has used that as a way to predict treatment response. So we did a recent meta-analysis, which is now published, which showed that people with who were on clozapine, especially one particular biotype, the biotype 1, had low levels of certain EEG waves, which we call theta waves, and also in the gamma and beta waves. The lower it is, the better they respond to clozapine. And when clozapine is used, clozapine increases or reverses that deficit of these brain oscillations. So this is one way in which the biomarkers that we have been using might come for practical clinical utility. So we actually found that it's a little bit of a complicated slide, and we found that biotype 1, this is all in biotype 1 is in red. When they were off of clozapine, they had dramatically low levels of delta and theta waves. But when they were on clozapine, that deficit got reversed. So this is an interesting observation that there is a treatable biomarker, that is low levels of what we call intrinsic brain activity, characterized by this kind of brainwave oscillations. And risperidone doesn't seem to have that difference. Clozapine, this is unique to clozapine. And so for this reason, we argued that biotype 1 might be especially responsive to clozapine. It's because they have these low levels of brain responsiveness to stimulate. Biotype 2 may actually not do too well on clozapine because there is already a high level of this activity. They may do better on a drug like a mood stabilizer like valproate. We have not tested that. But we wanted to test this question in biotype 1 versus 2. So that is an ongoing study, which is called the clozapine study, where we randomize individual to receive either clozapine or risperidone. They have a 90 to 10 chance of getting either clozapine or risperidone. So this is good. People who are especially looking for clozapine, we'd be interested in randomizing them to this trial where they get clozapine 90% of the time. And then we do an EEG before and after treatment. And we look at, first of all, whether they respond to treatment, and secondly, whether this biomarker was abnormal to begin with and got reversed with the treatment. So that is our clozapine study, which is currently ongoing, and hopefully will be able to successfully complete the study so that we'll have a biomarker for clozapine treatment in the near future. So the summary of this part is that there are very few treatment-relevant biomarkers in psychiatry, but cognitive and non-invasive EEG tests might come close to biomarkers that are useful. They may help predict not only outcome in first episode psychosis, but also treatment with clozapine. So I think that is my last slide. I am close to time now. We have a good length of time to discuss questions and any answers. I'll stop sharing at this time.
Great. Yeah, thank you so much, Kesh. It's always so interesting to hear updates from these studies, and I think really compelling around this idea of just diagnosing based on adjectives versus what's actually happening in people's bodies, and that actually correlating with how safe and effective different treatments might be for folks. Um, I, if folks want to unmute or put questions in the chat, please do. I wanted to just open it up by asking, what do you think is needed either, in the research or in the world for us to actually transition over to biotype diagnoses rather than the current DSM? It seems like kind of a big, unimaginable switch, but it does feel like the future.
Sorry, can you repeat that question? What?
Yeah, what do you think is needed, kind of on a social or like national level to make this switch from DSM to biotype diagnoses?
Yeah. So what is needed is first of all acceptance, because any change people resist, and if you begin saying that DSM diagnoses are not adequate to help outcome prediction and selection of treatment choice, there are going to be many people who will get upset. And especially professional organizations don't like it. So there has got to be a shift in thinking. So that's the first thing. And so people like me and others in my group, we have to be really, um, talking at the top of our voices to make that paradigm shift of change in thinking. The second thing, which is really something that is a challenge for everybody and requires, um, you know, resources and funding and support, is to establish these very provocative findings that we have in multiple studies, so that in science, if something is not uh, widely replicated, it doesn't really catch on and does not change minds. So we need other people to replicate these results in larger samples. So more research is needed. The third thing that we have to do is to develop ways in which these measures, these biomarker measures, are easily available to the community and easy to do. I'll give you one example of why DSM, the way it has evolved, has really not embraced the concept of the underlying biology as an important contribution to the illness. So DSM-4 was classified psychiatric disorders based on symptom clusters. All DSM classification schemes have done that. And in DSM-5, there was a lot of excitement. How about adding some biomarkers? At the very least, why not add a cognitive battery? Because cognition is the closest marker for biology, which we have seen, a lot of people have seen that cognitive impairment is the one that is most strongly associated with brain structural and functional abnormalities. So there was a lot of debate in DSM committees, and they gave up the idea of including even cognition in DSM-5 classification. Why? Because people don't have the facilities to do a cognitive battery. Come on, you can't say the same thing in like the rest of medicine. So if you say that doing a blood sugar measurement is expensive and not all places have a lab, and so treat diabetes without blood sugars, where would we be in the rest of medicine? If a clinic says buying a blood pressure apparatus, sphygmomanometer is too labor intensive, let's just treat high blood pressure without a blood pressure measurement. Doing a cognitive battery is not too much complicated. There are batteries that can be run using computers, such as the backs that we use, which takes 25 minutes, not a lot. And you get a good, reliable reading. Okay, so when it comes to biomarkers, neurologists don't treat epilepsy without doing an EEG. And it takes 2 hours to get an EEG, to get a good, full resting EEG with all its other provocations and so on. And EEG for psychiatric purposes to get a biomarker reading, like the type of factors that we do, takes about an hour. It doesn't hurt. It's just like doing an EKG. It takes a little longer. The person has to lie down and have these electrodes placed on the head with a jelly on top. There's no needle involved. It's non-invasive, completely safe. Takes about an hour. Takes somebody's time. It should not be that difficult to do it. And the same thing would be true in the same time you give a stimulus like a auditory click that they hear and measure the brain's response to the auditory click, which is what we call the evoked response potential. It takes a few extra minutes, gives a huge amount of information on how the brain works. Why should it be so difficult? Okay, even if it is difficult, let's say, which is what we thought about in the BSNP study, let us see whether simply using clinical information and using cognitive information, agnostic to DSM, can we derive biotypes? And we actually did that. And we developed an algorithm and we published it last year. It's called the ADAPT algorithm, where you don't need the EEG biomarkers. You can get just cognition and symptom ratings, and you can get a 95% confidence of identifying whether a person belongs to a biotype 1 or 2 or 3. So our field has not moved forward because of community pessimism and simply a set of lack of resources. And in some ways, psychiatry may be suffering from neglect of funding agencies, third-party payers, along with this pessimistic attitude. That those are the things that combine to get us in this state of stagnation in our field. So I think it's a long answer to a short question.
Yeah, well, it's not just a paradigm shift within psychology or psychiatry, but really in how we're situated with the rest of medicine too, it sounds like. Yeah.
Yeah.
So another question in the chat, this is really around, have you guys really talked with consumers or, folks with lived experience around developing this? So the question is the goal of shifting to a biotyping system as the basis of diagnosis something that aligns with consumer advocates who, very often have viewed this diagnostic process as having these inherent biases, things that don't address risk factors, struggles, what we were talking about, social determinants of health, that are most important to the people who are being served and are often used to deny autonomy of the people being served?
I think this is a fantastic question. We have not done that. We have talked to people with lived experience, and I give these kind of talks in NAMI and other places where there are people with lived experience and their family members, I always get a lot of enthusiastic questions, and people exactly ask these kind of things. But what Vera's question, is it Vera who asked this question? Yes. Raises in my mind is maybe there is a need for a focus group of community stakeholders to get input about this kind of a question. Thank you for
And
the
that
question.
kind of goes towards what you had said before about there needs to be kind of a community acceptance and understanding and buy-in to this
Yeah,
process
yeah,
before it can actually practically be
yeah.
used. Yeah, that's great.
I see a question from Samantha here. I'm still unclear about how you know what biotype group 1, 2, 3 people are a part of the clozapine research slides. When you mentioned biotype 1 had slower waves of EEG,
I
were
can jump
the
in. I didn't want to cut you off, but you were explaining it answered like part of my question when you were explaining just now about the EEG. So part of my question is answered, but there is still this curiosity I have about the categorization. So people are already going to be in there, like you will already have known people's biotype based on like the algorithm that you've said
yeah,
prior to the clozapine study and the EEG study, that slide
yes,
on?
yes, yes.
Okay. I
Yeah,
wasn't
yeah, yeah.
sure if that was what you
That
determined.
is the design of the study. We measure the amplitude of their EEG oscillations before they get into the treatment drug, the study drug, and then ask the question whether those who had the deficit at the beginning prior to treatment can predict if they were going to respond or not. And they did. In our cross-sectional study, it appeared that people who were on clozapine, whose deficit was reversed, were the ones who actually had gotten better. So that's the study now we are doing prospectively, where we are assigning people randomly to either clozapine or risperidone, and then look at who responds, and then look back and see whether those that did respond had the deficit to begin with. Does that answer your question?
It's definitely starting to make some more sense. I agree with Vera, the comment under my question too, that the variables that allow the machines to kind of make these categorizations is all so new that I'm definitely curious to learn more about it.
Yeah.
Thank you.
Yeah. So here is Leona from Chicago BSNP group. She's a question she's answering Samantha, I think. Do you want to speak up, Leona, and explain?
I feel like you explained it very well. From my understanding, I know less about the biotyping process, but that it's based on a range of procedures that we do,
Okay.
and that we do them at different points in time when our subjects are on medication too.
Right, right.
There's another question from Hyun Kim in the chat saying, can you share any updates on biomarker-based prediction for clinical high-risk populations? So especially in terms of prognosis, which I think you had a quick slide on that earlier. But yeah, what factors are related to conversion risk, treatment recommendations, et cetera?
Yeah, so this is a good question. Updates on biomarker-based predictions for CHR population. There is a large literature that has already accumulated. And very briefly to summarize, first of all, the imaging studies have shown that individuals who show gray matter loss close to the point of conversion to psychosis. In other words, gray matter thinning during follow-up in people who are thought to be at clinical high risk is a strong predictor of them developing a psychosis. So brain structural images may be giving us a clue. This is a data set that came from the Naples study and was published by Ty Cannon a couple of years ago. Other predictors that have been published were by Danny Mathalone. It was a paper published in JAMA Psychiatry a few years ago. Those who have reduced evoked response potentials or event-related potentials, especially the type called mismatch negativity, were the ones that tended to have higher likelihood of conversion to psychosis from a prodromal state. So EEG and imaging are both valuable. Thirdly, a number of metabolic markers of the immune panel, immunity markers, were thought to be related to the risk for psychosis. This is data published a few years ago by Diana Perkins from UNC. So there are a number of these predictors that are being published. In fact, another one in which one of our own postdocs, Gushe Collins, she published in Molecular Psychiatry. She showed that those who converted to psychosis had an abnormal organization of their brain using functional imaging studies, fMRI. So putting all of that together, it looks like there are several biomarkers which, used in combination with clinical measures, such as cognition, impaired cognition, have a value in predicting conversion risk to psychosis. Now, you asked the question as to what are the treatment implications, or what are the treatment recommendations. So the question is, what treatments are the best in terms of preventing psychosis and also improving functionality in people at clinical high risk for psychosis? One of the early lines of thinking was that low dose atypical antipsychotic drugs like risperidone will reduce risk of conversion to psychosis, which did turn out to be the case. And they say a similar finding was published by Scott Woods from Yale as well, the first one from Pat McGorry in Australia. However, only a small proportion of people in the prodrome, probably at this time around 10 to 15%, end up developing psychosis. So if they have not developed psychosis yet, and you put them on, let's say, risperidone, what is the likelihood of them developing unwanted metabolic side effects and weight gain and risk of diabetes and so on, versus the small chance that they may not develop psychosis? So the benefit-risk ratio of medications is pretty low when it comes to clinical high-risk populations. The treatments that are more likely to be safe and effective in the prodromal population are psychotherapeutic treatments like CBT. Can anything help us predict whether psychosis risk can be reduced by CBT in the prodromal population? That's an ongoing research, and we don't have direct results from that yet. But time will tell.
Thanks. Yeah. And we have another question, which I think this really gets to the core of this talk, which is, do you think that studies based on purely DSM diagnoses lack any real validity? So much of the body of psychiatric research is based on these subjective diagnoses from the DSM, which are subject to change. They've changed already. They're subject to change in the future. Do you think we'll look back on much of the current field of psychiatric research as being mostly irrelevant specifically because we're not using biomarkers.
Okay, so I mean, you would get a long answer from me for an interesting and somewhat complicated question.
Yeah.
I would not dismiss the value of clinical classification. Just think of an example in the rest of medicine. When you have a tumor, a swelling somewhere in the body, and you go to a cancer doctor, the cancer doctor might first make a diagnosis, or let's take not even cancer. Let's take the example of chest pain and breathlessness. Okay. And or headache. You need a general practice doctor to make a diagnosis that this person has a severe recurrent headache, which is a phenotypical diagnosis. Basically, it's a superficial level diagnosis, but you direct the patient to the right kind of doctor. That is what DSM could do. When DSM diagnosis classifies people into a broad spectrum of clusters of categories, like I know this person has a psychosis spectrum disorder, or this person has a trauma-related disorder, or this person has an autism spectrum disorder, and so on. They do have a value. They have a value in broadly identifying where to go next, which kind of further assessments and workup needs to be done, and so on. But it should not stop there. So back to the headache example, if you simply make a diagnosis of a headache disorder and treat it with a pain medicine, you don't get anywhere, right? That's where we are in psychiatry. We make it a diagnosis of psychosis and treat with an antipsychotic and stop at that. That is inadequate. It's like a one size fits all kind of treatment by making a symptom-based label. But a headache doctor will then say, okay, you have a severe recurrent headache. This could sometimes be due to a brain aneurysm. It could be due to a brain tumor, or it could be simple common migraine. Let's do a brain scan. And then the second diagnosis comes up. The person has a severe recurrent headache, and this may be related to a tumor in the base of the brain. So you need both. You need a clinical diagnosis to broadly identify the next steps as to what further workup is needed. And then you need a diagnosis based on investigations. Let's say you do make a diagnosis of a brain tumor based on a scan. That may still not be enough. The doctor may have to order a test or a blood test to see what particular tumor marker the person has, whether it's a, glioma or whether it is something else, because that can give the person, the clinician, an idea as to what particular treatment, whether it's a particular form of chemotherapy versus radiation versus an immunotherapy might work better for this patient. So you need multiple levels of diagnosis. You need a diagnosis based on symptoms. You need a diagnosis based on the imaging results, and you need a diagnosis based on under the microscope what you see the pattern of this particular tumor might be. In psychiatry, we probably will not go there that far, because most psychiatric disorders do not have a structural, they do have structural alterations as their basis, but they may not have something like a tumor that explains most cases under the microscope. Most of psychiatric disorders are related to brain connectivity issues, and of course, interacting with environmental risk factors and genetic risk factors and so on. So what I'm advocating in DSM is to move towards a multi-axial classification, not the old multi-axial classification, which really was like, axis 1 is psychiatric disorder, axis 2 is personality disorder, axis 3 is, comorbid medical illness, and axis 4 is level of functioning, and so on. That really did not take us very far. But what we need in psychiatry is an axis 1 that gives us the phenotypic clinical diagnosis. Axis 2 would be the biological diagnosis. Now, maybe you have a biotype 1 of electrophysiology in the brain. And then axis 3 would be an etiological diagnosis. You have a biotype 3 type of psychosis that may be related to the cannabis excessive use. Or you may have a biotype 2 psychosis that may be related to childhood trauma. Or you may have a biotype 1 type of psychosis that may be related to polygenic inheritance. So you need 3 levels of diagnosis, which is where the field should be going.
So there
thanks for
there
asking.
is still a place for the DSM diagnoses, but ideally in the future, the treatment decisions will be made based off of people's biology and things that we can measure rather
I think
than
all of
just,
them. You need good clinical history. You need to talk to people with the illness. You need to understand the various factors that might have contributed to the illness in a given individual, all the social determinants. You need to get a good history of the family history. You need to get biomarkers, whatever is relevant for that particular individual, and you combine the data to do this kind of a revised multi-axial diagnosis that I talked about.
And really like individualized care. Yeah.
Yes, that is what would lead to what
And
is
that
called,
actually, so related to that question. Oh, sorry, go ahead.
that is what would lead to what we call precision medicine down the road. Precision medicine, another name for that is personalized medicine. But that's also not enough, in my view, in psychiatry. You need a person-centered medicine. I'll come to that after your other question.
Well, this is maybe related, but a question on how do you see the biomarker or biotype work impacting psychosocial treatment selection for people with early psychosis?
Oh, that's a great question. So, for example, if you find that the patient has a biotype 1 due to reduced neuronal activity, you would want to use a cognitive remediation approach that is of an activating type, okay, which is basically to enhance the fundamental basic cognitive functions like attention. On the other hand, if the person has a biotype 2, which is due to a kind of a brain that is overly cluttered and has a very noisy response to brain activity, you would want a different kind of cognitive remediation that involves higher level top-down executive function training. But of course, a biotype 1 would also respond to neuromodulation that involves a stimulatory type like GMS or an anodal transcranial magnetic direct current stimulation or clozapine. And for a biotype 2, where it is more of a neuronal noise, you need a inhibitory type of neuromodulation, such as cathodal transcranial direct current stimulation or a mood stabilizer like valproate. So it's a more granular question. We can talk about it later. But suffice it to say that biomarker information can tell us which psychotherapy is likely to work for which kind of patient. But you did raise the question of personalized medicine. So I can take a minute to explain that. What is personalized medicine or precision medicine? Basically, precision medicine, which is the way the rest of medicine is moving towards, is the approach of identifying the specific cause for a specific syndrome in a given person and developing a specific intervention. Treat the right person with the right treatment at the right time. That is the mantra of precision medicine. To give you an example, in recent days, there has been a recognition that some types of psychosis, some of you may have read this book called Brain on Fire, which came out as a movie as well. There was this young woman in New York who was a journalist who developed a severe psychosis. She went to several hospitals, including a state hospital. Nothing seems to have worked with her psychosis. And then a smart doctor found that she had a condition that was producing antibodies against her own brain. These are called NMDA receptor antibodies. So she had what was then called an NMDA receptor encephalopathy. So this was a psychosis due to NMDA receptor encephalitis or encephalopathy. So the treatment for that was basically an antibody treatment. So basically give her a plasma infusion. And she got cured. Now she has no schizophrenia, right? So there are these kinds of examples. This is only one example of a precise cause for a condition that is treated with a precise intervention. This is called precision medicine. And it was personalized because this particular person had psychosis due to this particular cause. And so you treated that. So precision medicine or personalized medicine is the way, many branches of medicine are going, including oncology, which has made a lot of progress in that. No one tumor is similar to the other tumor. Every tumor has its own molecular configuration, and everyone has its own specific treatment approach and so on. This is happening in other branches of medicine as well, like in neurology. Different types of epilepsies have different genes causing them, and the genes might have different molecules that underlie these particular types of epilepsy and specific treatments. Psychiatry is going in that way, but much more slowly. That is precision medicine. But let me tell you a little bit about another aspect, which is psychiatry is probably more ahead than the other branches of medicine, if they practice it right. And that is called person-centered medicine. What is the difference between personalized medicine and person-centered medicine? We'll go back to the same lady with the same condition with an NMDA encephalopathy causing psychosis, and she got treated with antibody treatment, and she got better. Think of another patient who has the same thing and is prescribed an antibody treatment using plasma infusion. But he says, I don't want it because I'm a Jehovah's Witness. Blood products are forbidden in my family. So in other words, here you have to adapt your treatment to the individual's cultural background, socio-cultural background. Many times we forget that. So personalized medicine is not enough. It has got to be person-centered as well. So in this case, okay, you can't have antibody treatment, but maybe we can get you a high-dose steroid treatment. And let's see if that works. So it could work. It is a second choice if treated, used in and of itself. But it could still work. So treatment has to be decided based not just on biology, but based on the whole environment, biopsychosocial environment that the patient presents with.
Thanks. Well, looking at the time, we have time for maybe one more question if anybody else has something they want to ask. If not, I do think that is a great kind of idea to end on. Yeah, thank you. I'll echo in the chat. Really, really helpful, really interesting to hear
Yeah,
about
great
this.
questions. I have learned a lot from these questions myself. So appreciate it.
Yeah.
Yeah.
All right. Well, great to see everybody. Thanks for showing up and have a great rest of your Friday.
Thank you.
Thank you.